And I hope it's okay we record it.
Yeah, it's okay.
It's very kind of you to take the time to do this. Everyone here has been looking forward to, because I know you, a lot of you know you pretty well. And it's getting cold out there, right?
Yeah, I was 15 last night.
We're gonna get it. Not like you yet, but
Yeah, everything moves from the west to
I
the.
know we watch it. We watch it coming. Um, are you from Virginia? Are you from down south originally?
I was raised. I was born in South Bend, but I was raised mostly in West Virginia.
You were, okay, because I didn't realize that, because I had always thought of you from Iowa and then Rush, of course, but for many years at Iowa, you know.
Yeah, 20 years in Iowa, and then
Yeah.
came here in 2009. So I guess I'll put 20 years in here eventually. Here.
We hope, right? Well, listen, you've been right on time, and I really appreciate it. So I'm going to kick this off. There'll be people joining, and some of the little square blocks you see are not individuals, but conference rooms. So there'll be a number of people on this. And we very much appreciate you taking the time to do this. Vince Traynelis is well known to, I think, everybody who's on the line. And we have some people from around Boston on as well, in the area. But Vince is from West Virginia, he just told me, but he went to school in West Virginia School of Medicine in Morgantown, and then stayed there for his internship, residency in neurosurgery. But then following that, moved to Iowa, which is where I mistakenly thought he was kind of from that area, because he was there for 20 years, rose to the rank of professor, and then went to Rush, where he's been incredibly successful setting up and running the program there. And he's the A. Watson Armour and Sarah Armour Presidential Professor. He's the vice chair of the department. He's not only chief of the spine service, but he runs the neurosurgery residency and the spine fellowship. So he's well versed in graduate education, and he's been a real contributor regionally and nationally along these lines. He has focused his practice primarily in the spine and craniovertebral junction, which is phenomenal, and it really shows how a virtuoso can work in one area. And really, because I know, because he may not know this, but I've actually referred patients to him who've done exceedingly well. And in any event, he's also contributed on a national level to neurosurgery. He's a past president of the Congress. He is, I think, president-elect of the CAST committee, which has become very instrumental, as everyone knows, not only for vascular, but for spine, bringing together different specialties to achieve accreditation for subspecialization. But Vince is well published. I think lots of people here, we've journal clubbed his articles. And with no further ado, I would like you to share your screen and kind of take the lead and for rounds this morning.
All right. Thank you very much, Chris. Pleasure to be here. I'm going to share this. It may be a little messy. I've had trouble. Somehow I'm stuck in this presentation mode. And let me just see if I can make it work. We'll try screen 2. How about that?
That is working. That's visible. Thank you.
Okay.
It's a little bit in presentation mode. We can see your next slide coming, but
let me just
but that's
that. Yeah, that's what I mean. Displays.
If it's in that mode, we can definitely see it. Oh, beautiful. That's perfect. Yep.
All right. Well, I'm going to talk about geriatric odontoid fractures, but we chatted about weather just a bit ago. Here's O'Hare this morning, 15 degrees. A little snow on the ground, so it's coming your way. Just thought I'd let you know. And here are my disclosures. And we'll get to it. As we all know, odontoid fractures are approximately 20% of all cervical fractures. And 60% of these are type 2. Mostly, we all know the Anderson, Alonzo 1, 2, and 3, but there's also the Jefferson group also subdivided these, this Grauer classification. And if we look at this screen, instead of just looking at the straight across the base of the dens standard type 2, they called that an A, and then depending on the angulation of the fracture, subdivided it into B and C. And C is particularly important because it has that little chip of bone. And The Barrow experience, published by Hadley so many years ago, called that a type 2A. And every single patient in their series that had that extra little chip across the fracture line failed to heal with non-operative management. So something just to keep in mind. Although most of the patients we see in the emergency room seem to be asymptomatic, actually there may be about 1 in 5 with a neurologic deficit, and a lot of these are come from autopsy series. People found to have a serious cord injury and never made it to us. So even though we may take this lightly because people look good, they are serious injuries. Most of the patients are older, as we know, and so some baseline. So I'm going to introduce you to Denise. Denise is a 91-year-old woman living independently, tripped on her carpet on Christmas Day, 2018, and fell. Her son was there. No loss of consciousness, no neurologic symptoms. She just tripped. But she had severe neck pain, went to the emergency room, CT scan, found a type 2 odontoid fracture. Her past history is remarkable for hypertension. She had cataract surgery. Her hemoglobin at that time was 11.2, which you might find curious for me to mention, and we'll come back to that. And her exam was normal. And here's her CT scan. We see that she has a diastatic, slightly posteriorly displaced fracture. I'm not calling that little chip in the front type 2A or a Grauer B, but she has this posterior displacement. And if we look at the axial, she probably has a remote C1 arch fracture in addition. And so Denise fits what we know. We know that these are injuries in elderly patients. We know that they are increasing in incidence as time goes by, and she fits that demographic. In fact, if we look at this NIS study over 14 years, looking at 31,000 patients, we see that the hospitalizations are increasing. And if we look at this graph, they're increasing the most in the demographic that's older. So the older you are, the faster the rate is climbing. And our population is all living longer. So this is serious concern. Treatment options. So the patient comes in. What can we do? And here are the list of options, at least as I see them. And we'll start with no treatment. There's actually a paper about no treatment from the Cervical Spine Research Society and published out of Iowa, in fact, with Augustus White from, Chuck Clark was in Iowa and Gus White was up in Boston. They had 18 patients, and it's not surprising, 100% failure, none of them fused. No treatment resulted in no healing of any sort. So next on the list would be some sort of immobilization. And traditionally, over the years, the decades, it was a halo. And depending on who you read, the success can vary from none of them work to 80%. But looking at a case control study, we found the patients over 50 years of age were 21 more times likely to fail in terms of fracture healing with halo treatment than those less than 50. So a huge impact on age in this patient group. And halos, probably none of your residents have ever put a halo on, I suspect. But halos used to be a common thing, and they have their issues. If we look at this study coming out of a trauma journal, they looked at old patients, which had a mean age of 79, and compared them to a young group, mean age 38, and looked at treatment and found that despite a higher injury severity score in the young patients, the mortality with halo treatment was 21% in the old group and 5% in the young. And so this was a very concerning trend, and there are a lot of complications. Most of them have to do with the pin sites and perforations, a lot of pulmonary problems, but the halo itself is not a totally benign treatment. And so what is the option if we're going to mobilize and not do surgery? What are our other options? And here's a study looking at halo vest and non-halo vest immobilization, which is a rigid cervical orthosis, Philadelphia collar, Aspen, something of this nature. And if we look at the complication profile with just a orthosis, not the halo, it's much less, 38% complications versus 66. And so this looks like a good alternative to the halo. But, does it work? If we go back to the original study by Anderson and Alonso, they actually had about a fair number of patients succeed, 66%, with just a rigid orthosis. But if you read the article, these patients were in traction for 6 weeks, and traction is very rigid. And so they had an initial fixation or immobilization almost equal or probably better than a halo before they went in the collars. But most people don't do this. We never did it. We put people in a collar and we hope that it works. Here's a study from the AO group looking at 58 patients treated with rigid orthosis. A number of them died in the first 3 months, and so 50 were studied out of the group. And they found that 30% had non-union. And if they looked at those patients, this was the overall group, those with non-union and those without, were no different in their NDI and SF36 at 1 year. But they operated on almost half of the non-unions. And they still counted them as non-union. So it's hard to say that this NDI and SF36 difference is really real since the non-unions were fixed. From the same data set, Valines looked at a group of patients and looked for what he defined as treatment failure. And the criteria was either death, major complication, or decline in NDI by more than 9 points. And if we look at the group, what's associated with failure? Older age, initial non-surgical treatment, 3 times more likely to fail. Male sex, and of course, baseline neurologic comorbidity. So failure associated here in this study with non-surgical treatment. And if we look in the literature, there is a growing body of literature saying that non-operative management or reporting non-operative management associated with higher mortality. Here are some papers. In fact, just from this summer, the Northwestern group looked at this propensity score matched analysis and found that surgery decreases non-union myelopathy and mortality for patients with traumatic odontoid fractures. So something to be aware of. Now, I talk about this in many venues, and I'm not going to ask questions here. It's a little harder on Zoom, but usually I ask for a show of hands. How many people operate? How many don't? And most of the audiences put up their hands. In older patients, they prefer orthosis. But if we look at this study, 32,000 patients ranging all the way up to 2017. The operative treatment in 2003, 46% were operated. 2017, 86%. The lines crossed around 2005. So if you choose not to operate, you really are in the minority. And so people say, oh, I don't operate. But if we look at what really happens, it is surgery. And in this big group, if we look at mortality, the operative 3.6%, non-operative 5.9%. So less mortality. Now, we could say that these patients were cherry-picked and the really sick ones didn't have surgery. But it's a little hard to do that when you're talking about 32,000 patients. But nonetheless, that could have something to do with this lower mortality. And so we'll give you that. So with this background, I eliminate from my treatment algorithm the first 3, and I move to surgery. And our options are anterior or posterior. So we talk about anterior. Of course, anterior screw, first described in the early 80s. The idea is it'll spare the rotation. We're simply fixing across the fracture line. We don't need a graft. We don't need a halo. Elegant procedure. But it may not be quite as good as we think. Biomechanical studies done a decade or so after the technique was developed showed that the screw was as stable as wiring. There weren't posterior screws at this point. No difference if we put 1 screw or 2 screw in. There used to be a lot of debate about how many screws should we put in. And we have to keep in mind that at least in this report from the Barrow, 10% of odontoid fractures have ruptured transverse ligaments. I don't know that I've seen that in my practice, but it's certainly something you have to look for and consider if one is going to do an anterior fixation. How does it work for the elderly? This is the Utah experience by Ron Applebaum, published by Daly. And 57 patients and 57% fused. Another 24% didn't fuse, but they had what was described as a fibrous union. So in flexion extension, they didn't move, but clearly there was no osseous union across the fracture fragment. And 19% had a frank non-union with mobility. It is interesting in this study that when they subdivided their patients into those that had a single screw, they had a 56% stability rate, whereas those with two screws, 96%. And so I would submit to you, despite the bench biomechanical data, if one chooses to use an anterior fixation for these odontoid fractures in elderly patients, you should strive to put two screws in, because this clinical study shows that the result was much improved with two screws rather than a single screw. But the technique has problems in older patients. A number of them have serious dysphagia, a quarter of them need feeding tubes. Pneumonia was a problem, but pneumonia is a problem in all of these patients. And so don't take that to heart, a couple of MIs. But more importantly, the bone quality is poor. And these screws tend to cut out in the osteoporotic elderly odontoid fracture, leading a number of surgeons to abandon the technique after seeing a number of failures. A couple papers here that support that concern. And so I'm going to take this off the list for the elderly patient with the odontoid fracture, which leaves us with some sort of posterior fusion technique. And we have several listed. The Brooks fusion, wire fusions are of more historical significance since we now all use screw fixation. Wire fixations have a number of success depending on whose paper you read, but excellent results with rigid fixation using screws, either transarticular or screws into the lateral mass of C1, and then either pars, pedicle, or lamina C2 screws. In fact, the results with posterior fusion are so good, it led the AANS CNS Guidelines Committee to give a level 2 recommendation that surgical stabilization and fusion should be considered for type 2 odontoid fractures in people over the age of 50. Now, these patients are older. And there is concern, are they too frail for surgery? How long will they live? Is this just a sign of someone whose entire system is failing, this type of pathologic fracture? The same sort of issues that the orthopedic surgeons struggle with hip fractures. Here's a study from Britain, the Nottingham Hip Fracture Score, which was found to predict 30-day mortality in patients with a hip fracture. And it's a simple score. They look at age, so you get scoring for age, sex, admission hemoglobin, a little mini mental status test, 10 questions, whether or not they live in an institution, how many comorbidities, and whether or not there's a malignancy. And so depending on what the total score is that you add up, it can predict 30-day mortality. So this could be useful, should we proceed or not, at least a point of discussion for the patient and the family. Now we'll get back to Denise. It's hard to believe, but in this day and age in Chicago, she was put in halo by a neurosurgeon. She had severe pain and, in fact, increased angulation and posterior subluxation. So the halo failed for her. If we look at her score here, if she had a hip, her age, 4 points for age, but she doesn't get any more points. So her total score is 4. And if she had a hip fracture, her 30-day mortality would be 6%. So she's going to be around, it seems, if she had a hip fracture. But another group in Britain took the same Nottingham score and retrospectively applied it to 82 patients with odontoid fractures, the outcome of who they knew. And they found that the Nottingham hip fracture score was an independent predictor of mortality at 1 year in this group. And they had a way of stratifying patients into who would have higher mortality at 30 days and 1 year. So using another fracture score, this also relates to odontoid fractures. So we would say with this that Denise would be potentially a good candidate. Now I'm going to change gears a little bit, talk about my experience. I looked about a year ago at 93 consecutive patients treated for odontoid fractures. And here's the demographic here. And I will flat out say that I offer surgery to everyone. I operate on everyone. And so I'm not picking who gets surgery or who doesn't. You know, unless someone is coding when I meet them, I'm going to offer surgery. I want surgery in 24 to 48 hours. I want them fixed and out of bed. And so these patients there is no non-operative group that I have to compare them to. The cause of injury in all was a fall, except 8 was a fall, a couple automobile accidents. One was an interesting event. We look at this paper published in 2005, cervical injuries in ocean bathers at Puerto Vallarta. And when I read this article many years ago, I was fascinated by it. Here's a picture of the surf pounding in. One of the patients in my series had a fracture they suffered at Puerto Vallarta. They were thrown into the sand by the surf. They went to the local facility, told they had a fracture, and promptly flew home. So that's how I got this patient, but interesting sideline. Neurologic status, 3 of these patients did have severe spinal cord injuries. 7 had myelopathy, and it probably was a myelopathy that predated their fracture and perhaps even the reason they fell. 37 patients, a pretty big group, had additional fractures, mostly C1 fractures. Comorbidities are just what you would expect in a group of patients of this age, listed here. And I had 3 deaths in my series, mostly pulmonary problems. The first death, 89, 83, 84, and you see the data here, but the complications were pulmonary edema, pneumonia, sepsis, and another sepsis and renal failure. And so 2 of these happened fairly quickly. The other was a couple weeks out. My complication profile is here. And again, mostly they're pulmonary problems. In fact, if we look at the risk of complication, what's the most common complication if we operate on someone with myelopathy? Pulmonary. We talk about neurologic deficit, wound infection, dysphagia, whatever you want to talk about. But if we don't mention to the patient they have a risk of pneumonia, then we're not really telling them what the real risk of the surgery is. So same in this group. Now in my group, fixation's all over the map because I get easily bored and distracted. So depending on what the problem is, I use different techniques. Also to help with resident education. So here we have it. And here's my technique. We'll go into a little bit of a surgical technique. I don't use any monitoring except fluoro. That machine is my monitor because if that, so everyone has lead on, anesthesia, everyone in the room's got lead on, x-rays in the room, turned on, ready to go. So the minute we turn, I move the C-arm in for a lateral and I manipulate it under live fluoro. And if the spine is aligned, the neural elements are not compromised. And so that's how I do it. And if you look at my hands too, also for all procedures I do, I wear lead attenuating gloves because we get a lot of fluoro and anything you can do to avoid a little extra exposure is good. So I line this up under fluoro and then we lock it down. Now, the fixation techniques, transarticular, excellent fusion rates, reported by multiple authors, mostly some wound infection problems, but by and large, this technique works well. The problem with it, and it is a historical note now, because I know most surgeons don't do it, is that there has to be proper reduction. You're somewhat limited by the anatomy. If there's a large kyphotic upper thoracic area, if the vertebral artery is in your way, these are things that can preclude you from placing the screw properly and safely. And you need to come in around T1. So most of this is done percutaneously, so you don't have to dissect that low. And alignment is important. And I will pass through this quickly because I suspect most surgeons are not using this technique anymore. And even with this, you can still miss. Now, for transarticular screw, and also maybe your lateral mass screw, the target on a fluoro is the anterior arch of C1. But if we look at these screws and say, oh, these look pretty good, they're placed to the anterior arch of C1. But you have to remember that it's a curved ring. Here's a CT of that same patient, and you see because the lateral mass is going to be posterior to that anterior arch, you've got to stop a little short, or else your screws will be proud. And that's true also of C1 screw. It's important to study the sagittal CT. I don't get 3D CTs. I don't get 3D CT angios for a standard fracture, because if I know where the foramen is, I know where the artery is. Important to achieve anatomic alignment, and to always remember that the vertebral is lateral and the carotid is anterior, and this is the hypoglossal nerve. So here in this cartoon, we have a transarticular screw, but we also have what a lot of us do, C1 lateral mass, and here a pars screw, and you still have that carotid artery at play. In fact, paper out of Mayo Clinic, Brad Currier, a post-op CT scan on a patient just to look at, see how things were, and found the screw abutting the carotid, and were concerned enough to revise that screw. So keep in mind that the carotid is out there, as is the hypoglossal nerve if you're a little bit lateral. So exiting, if you're going to go bicortical, a little medial is safer for both the carotid and the hypoglossal nerve. Just some points to keep in mind. C1, C2 fixation, initially described by Goyle in Mumbai, 100% fusion rate. He used these little plates, and in fact, I operated with him probably 8 years ago in Mumbai, and he still uses these little plates, while the rest of us use polyaxial screws. But the paper most frequently quoted is the Harms paper using the screws, 100% fusion rate, no problems. Now, some people place their lateral mass screw in C1 by what they call through the pedicle. And in fact, here's a paper written about how to expand that a little bit. And the idea is that we don't have to dissect down deep into the area, and there'll be less bleeding. But that vertebral is sitting right there, and that, quote, pedicle is just a little thin layer of bone. And I don't prefer this technique, and I think that if you use it, you are putting yourself at your patient, a little increased risk for vertebral injury. In fact, if you're going to use this technique, you need to get a microdissector and lift that vertebral, or just keep that between the vertebral inferiorly and the bone to help protect with your drilling. So it's a published technique, but it's something that I'm not very comfortable with. So my technique, I'm going to walk through. First of all, I don't use a drill guide. In the sawbones, you can see with the drill guide in there, I think there's C2 root ganglion and some regorged veins. And I put that in. I can't really see where my drill is. I can't see where I am on that little lateral mass. So I prefer to use a K-wire and then expand my hole just with the drill. And here's how I do it. So got my K-wire in, I got a sucker. And I take a single fluoro shot, and I say, well, how's that look? Well, not so good. It's a little low. I'd rather be up higher. I'm just in the lower part of the lateral mass. So I readjust, and now things look a little bit better. This looks like a better trajectory for me. So I start the drill in the center of the lateral mass, and you wait. I just wait and wait and wait until it drops. And now it drops. Then I shoot another fluoro shot. So I'm through the posterior cortical bone, I'm in the cancellous bone, it flows smoothly through there. And then you feel it hit that rigid anterior bone. And I sit on that. Well, I don't, the fellow resident does. using haptics until it drops. The second it drops, we stop and shoot a floral shot.
So
Now,
Vince, that's what you mean when you say drops. On the back edge, you just feel it, and then when you
feel the
feel the drill
haptics,
just slide in.
all of a sudden, there's no bone in front of you. And if you shouldn't stop, because if you stop, you lose a little bit of that tactile feedback. But if you do stop, then turn it on, back it up a little bit and go forward, and you can tap, tap, tap and feel that you're still in bone. But as soon as that goes away, stop, shoot a floral shot and save it. So now I know that's bicortical. A screw going there is bicortical. So I expand the hole just a little bit with this drill bit, and there's no feel to this. You put this in, and usually I just turn it 6 times with my hand and shoot a shot, and you may find it's all the way there because the bone is so poor. And then I put a screw in, and I match my screw roughly to where that first K-wire dropped. So now I know I'm bicortical fixation here. I'm not too long, and I'm not too short. And of course, we know we need to estimate our screw has to be taller. Usually these are what, 32, 34 millimeter screws. I've always used threaded screws. I'm not a fan of the smooth shank. I've never had a C2 root problem. It's all rigidly fixed and fused. And the reason I like the fully threaded screw is if someone has a big lateral mass, I want threads in every bit of that bone. I don't want to have just a little short group of threads and then smooth shaft in a place I could get fixation. And so so that's my C1 lateral mass technique. For C2, we can use the pars or the pedicle. I generally prefer the pars because it's the same trajectory as a transarticular screw. So you're doing the same thing again and again, but there's nothing wrong with the pedicle, and biomechanically, the pedicle is a little bit stronger. But I tend to use that as a bailout. But for either one, you have to study your CT scan. Initially, it was stated that the pedicle fixation was always safe for the vertebral, but if we look at this axial, I would challenge anyone to put a pedicle screw on the right in this patient and get purchase and not injure the vertebral. So you gotta look at the sagittal and the axials when planning it. You're not going to get a pars, you're not going to get a transarticular screw in that sagittal we're looking at either. So study these CTs and look. And then Neil Wright writes this great technique that seems like it's sitting looking at us all this time, and it was genius. Now we can put screws in without putting the vertebral at risk. And it's just this translaminar technique. This is another one. I think it's important to look at the CT scan, the axial, because all lamina are not the same. Some are huge, and so you're going to put a bigger screw in, so your screw threads engage that cortical cone of bone, whereas others are small, so you're going to have to put in a 3/5 screw or something a little smaller. You don't need fluoro. You just dissect it out, look at it, use your eyes, guide yourself down. And this is an important one to probe to make sure you're not in the canal. And it's also important to, once you drill the first side, to put your screw in, because these drills are usually about 2.5 millimeters. So if you put a 3/5 millimeter screw in, as you're drilling the other side, it's a little bigger, and you'll know how you're going to get past it. A big bifid C2 process can be a little problematic. And then here's some failures. You think this is so simple, and I see these patients come in where they have almost no fixation. In fact, the lamina on the right there may be too small for a screw anyway. So there's still ways to make it go wrong, and who knows how this happened with this big, nice lamina, but things can happen. So you have to pay attention so that you'll get this kind of result, which is what your goal is. And just a cartoon showing you this, if it's a widely bifid large spinous process, then if you keep that both sides on there, like you go through bone, you're in airspace, you're going through a bone again. So in these cases, a lot of times I'll just take off one of the sides of the posterior process. Now, when screws first came out, they were all compared to wire techniques. Here's 4 important articles from that era. And in these biomechanical studies, they all were set up a little bit differently, used slightly different loads and paradigms for testing. But I took all these, I made a little scoring system of my own where if you get 4 pluses, that's the strongest you can be, and 1 plus is pretty weak. And the galley was a wiring technique. So which was very poor. So if we look at the Brooks fusion, which is really 2 sublaminar wires on either side, we have good flexion extension, better than average AP translation, axial rotation. If we use a clamp, which is not, only older folks will know about it, it's kind of like a Brooks, good flexion extension. But the screw techniques were not so good at flexion extension, but excellent at axial rotation. And if we think about this mathematically, there's a good explanation. Flexion extension, a tension band will stop the flexion extension movement. And mathematically, the strength of a tension band is directly related to its distance from the axis of rotation. And so if you clamp around that or wire around those posterior elements, they are farthest from the axis of rotation, which is right at the joint, whereas the screws are fixed right at the joint. And so there's a reason there's a difference in these. And this data has led me to always add a wire technique, a cable technique to my screws, just to improve my flexion extension strength. So here we have my just an example. So I have my screws in, and how I put this cable in. I have an O vicryl reversed. I just push this through here and then pass that wire. And then I suture, and then I'll tie the suture to a cable, and then pull the cable through, and I loop the cable. This is the Sontag or interspinous technique. I'll loop the cable around spinous process of C2. I have a couple notches in it, and then I take my bone graft and I set it there. And the bone graft, I've already decorticated the inferior part of this and the superior part of C2, and the bone graft's a little oversized. And so now I'm going to tamp it in there, and it's going to slightly be under a little bit of compression. So I'm going to tamp this in there gently, and it's going to spread. Now it's going to be there, and then I'll cinch it down with the wires. So that's how I get my graft in. It's an excellent place for me to put my graft, and I add this tension band to it. There's a lot of curves in these wires, and sometimes they're not quite as tight as you want them. So in that case, I may just thread one under it and then cinch it down to take a little bit of the slack out of the system. So that's my technique for getting this dorsal tension band in. I like to use rib. We could talk about that later if you want. So usually I use rib. I like autograft. In the days past, we never used allograft for dorsal onlay fusions, and now it's a common thing, and the results are not that bad. And I think it's because we have rigid fixation now, whereas in the past with wires and rods and such we didn't. But I still prefer autograft. I don't use much BMP in the patients. There were a number of patients with serious challenges with steroids and things. For these patients, I did add BMP. I didn't feel like I wanted to harvest rib, and I was concerned about healing, so I added a little BMP. And lately, I've been went through a phase where I was fusing at the C1-2 joint as well. And you see, I would clean out the cartilage, and here you see I've impacted machine cortical allografts into the C1-2 facet space. And this is really useful if there's a C1 arch fracture, because you don't know if the arch fracture will heal, and you got to get graft in somewhere. And these are under compression, just like an ACDF, and they're excellent grafts. In fact, they increase the stability. We look at this biomechanical study. We'll start out with the intact spine, maximum flexion extension, lateral bending, axial rotation. I think they had 1 Newton-meter load. And the injury in this study was a type 2 odontoid fracture. So we see there's more motion, flexion extension, 31% more motion than the intact. And the S stands for these spacers. And just putting the spacer in stiffened the spine tremendously. Adding the screws made it a little stronger, but just the spacers really stiffen the segment. And you'll see this when you pound them in. You could grab the C2 lateral mass and start wiggling it once you put these two in, and C1 will move with them. And so it's a very important step in the osteoporotic patient, because then I can load share with my screws. So I can make it stiff and take some of the work from my screws, and I have a great graft in there. So I've been a fan of that. I use rigid orthosis for 6 weeks, and then I CT them at a year because that's how I determine fusion. So if we look at this patient, these two pictures were taken on the same day, and if you look at that lateral radiograph, I can't tell if that's fused, but I get a CT and I know, all right, I have solid fusion. And a little bit about blood loss and technique here, that if you stay in the subperiosteal plane, it will not bleed. And here we are, subperiosteal plane. This is putting these little grafts in. So I will section the root. I'll lose more blood if I section a root than if I just dissect it. But here we're taking the root. Speed this up. And cleaned out here. I'm in the joint. I've cleaned it out with the curette. I have some rasps I can also use. Here's a rasp. We're going to drive that into the joint and help get more cartilage out. And so here's the space, and then we're going to put a graft in it. So that's, if you don't use these grafts, here's kind of how they go. Come in with a graft. There's going to be a lot of cartilage in there, so the little curette helps. But then here's looks like a 4 millimeter graft, and we'll pound that in there, and that's how we'll place it. And so we got everything locked up and put the rods in, and that's it. So what are my results? My results are a really pretty good fusion rate, with one exception, 67% fusion rate when I looked at early on when I looked at this with the laminar screws. So not so good. Why is that? I don't know. Look at this. Posterior subluxation, posterior displacement, lined it up, put the screws in, everything's happy. 1 month later, fractures out the back, lose all my purchase, ends up with an occiput to cervical fusion, very morbid. Here's some other examples, haloing around my screws. And so the initial biomechanical studies told us that transarticular and pedicle screws and cables and all this were equal to the laminar screws. But then later studies that didn't just look at flexion extension, started looking at lateral bending and other aspects, found that the C2 laminar screws were not as strong as pars or pedicle screws, and when used at 1-2. And so I think that this is true, and I try not to use these screws at all if I'm doing a 1-2 fusion. If you're coming up from the subaxial spine and you want to grab C2, it's different because you don't have to worry about that axial rotation, which is in line with the screw. It's really more of a flexion extension because one is going to rotate freely. But when doing 1-2 or 0-1-2, I think it's a real concern. And what can you do about it? This is a potential option. This technique for bilateral screws, so they're bicortical screws. If you see, this technique was originally developed by pediatric surgeons to be certain they didn't get the screw in the canal. And then the Miami group published it. And what you get a burr, and you have to, I use 2 millimeter burr for my entry hole. And that's usually all I do. But here, then you pick where your exit's going to be, and you might put a little burr hole there, and that's your target, and you come through. So this bicortical fixation may be strong enough. Another option I frequently will do is just drop down to C3 and put some screws in C3 as well. So Denise, I didn't tell you that 2-3 was already fused. And so here's Denise. We have her lined up. We got screws in, and we have her fixed. Now, the World Health Organization defines fragility fractures as noted on this slide, fracture caused by a minor injury. Although it is interesting, later in the document, they say this doesn't count cervical spine fractures for some odd reason. But let's be honest, these are fragility fractures, and patients with fragility fractures are very likely to have more fractures. And the risk can be decreased with drug therapy, and it is a cost-effective treatment. And so an important algorithm for us is to consider this. A number of papers show that the most important risk factor is osteoporosis. Sometimes there'll be some cystic changes at the base of the dens, and the fractures will come through there. And so certainly it's something to be concerned about, but the main problem is osteoporosis. And so at Rush in 2015, we established, this man, Sanford Boehm, established a fracture liaison service. So every fracture that comes to the institution is immediately seen by this team, and they go through an extensive workup and begin treatment. So we like to fix the fracture and move things along, but it's important to remember to get the proper people in your institution involved to look at the long-term bone quality and what's going to be important for this patient's health as their final years go on. And this is Denise. This is all the things they did on Denise. I'm not smart enough to know what they're looking for with all of this, but they do a number of blood tests, and they then design a treatment plan. And I think that's a really important aspect that we have to keep in mind. Now, what happens to the fracture we put these screws in? Here's paper again from Utah, and they reported, and these were a lot of young patients, that 90% of the patients, the fractures healed. And then comes these papers from Shanghai, which I think are honestly revolutionary. These surgeons use temporary posterior fixation without fusion in a number of patients, but they were young, mean age 40, and have a 96% fracture healing rate with temporary fixation. And they compared those two patients with the C1-2 fusion that wasn't temporary and showed better outcomes in terms of neck pain, NDI, and stiffness scores. And here's an example of this fracture. And they did a CT scan at 3 or 4 months. If it's healed, they took the hardware out. And then they did a follow-up study with axial rotation using CT. And they compared two groups. So first of all, if we look at our historical literature from Dvorak and Monkeberg, we have around 40 degrees of axial rotation. So with their screw, 40 degrees. Posterior temporary, they lost a little, 32 degrees, but they still had significant axial rotation as defined on CT. So it's a pretty high quality study. Now, what about older patients? There was a paper published in 2013 that said only 1/3 of them healed. But I went through my paper, my patients, and almost 3/4 of them healed. And in fact, this is Denise, 92, healed. Diastatic, displaced, healed. So this changed my practice. Here's the patient, first patient, 74-year-old man, mountain biking, really active guy, put in orthosis, 5 months. Fracture didn't heal, constant neck pain, couldn't do anything. Here's his radiograph, flexion extension, he's moving, and a CT scan. So I put temporary fixation. I did my whole procedure because I told him this might heal. If it does, we're taking him out. But if it doesn't, I'm not coming back. So I have my graft in the dorsal elements. Here he is at 3 months. Simple procedure, just to go back in, take out the screws, cut the cable, pull out the graft with the Lexel, and he's free. This is the first one. I was a little concerned about taking the C1 screws out because I didn't really know if it would work, but it did. And so he did well. Since then, I have done this to, I have about 5. I have 5 patients that are over the age, they're all over the age of 70, that I've done temporary fixation on. All of them at 3 months, fracture was healed, like at least obviously 1/3 of it healed, mostly posteriorly. I've taken the screws out and they've done well. They are all feel much better with the screws out. I have a non-invasive way of measuring flexion extension, axial rotation, lateral bending. So I've been doing this before I take the screws out, and then at 6 or 8 weeks after I did. And the amount of motion I can detect in these patients increasing is not very much. I'll be honest. It's not this kind of axial rotation that looks like it's normal. But these are older patients, and all of them feel that they're driving, and maybe it's placebo, but they just feel they can move better. What I measure so far is, maybe I got 10 degrees, but maybe that's all they need. And so that's I think a real consideration. If we can temporary fix people and pull the screws out, then I think that their quality of life is better. And so with that, I will close and have a few minutes for questions. It's been a pleasure to talk to you this morning, and I do appreciate your offer to speak, and it is a great honor. So thank you.
Vince, thank you very much. I'll certainly invite questions. I also neglected to mention that we are indebted to you for training Zeev Moses, who is now on our staff and
good morning.
practicing away.
But the KY probably.
As a non-spine person, this is fascinating talk because I have put many halos on in my day. But I would invite comments from the audience. Zeev, or
good morning, Dr. Traynelis. That was a great lecture, really fascinating topic. And so, in terms of, some people advocate more for a period of observation to see how the patient does, bring them back in 8 weeks. They're in a Miami J and assess, whether a fibrous union develops, how the neck pain is. What are your thoughts on that? And then also, we're using a lot of external bone stimulators, like Orthofix has them for lumbar and cervical spine. And there's some data that it can help with fusion rates, more in a degenerative state. What about the use of those for, rigid orthosis with an external bone stimulator? Is that something that would be interesting to look at?
Those are good questions. The first, in reference to the first, I do offer everyone surgery, and I operate on a number of people that other surgeons around here put in collars and send home, and then they have some pain and they find me, and so I'm just not a collar fan. I mean, but I'm not saying it's wrong. It's not malpractice. It's a standard technique many people use, and we're all just trying to sort through this. So it's not my treatment. The bone stimulator is an interesting topic. I think years ago I used to put in for difficult OC fusions or redos, I put in internal bone stimulators, and I'm convinced they work. They really work. But then you have to go back and take the battery unit out and so on. I have had poor luck with external stimulators, primarily in experience with ACDF non-unions. Never saw it work. So I used them many, many years ago, and then I took a break, and I decided 3 or 4 years ago that I'll try them again. Maybe the technology is better. I tried them. They still didn't work. And I had a single patient. I had a 1-2 fusion on. I didn't think that it didn't fuse at a year. And he was a young guy. And so we talked about using the bone stimulator. So he went home with the bone stimulator. He came back 6 months. I CT'd him. He fused. And I thought, okay, they finally work. So I'm talking to him about them. It's great. He said, no, I never wore it. I hate it. It was so uncomfortable. I couldn't stand it. So he was just a slow healer. And so I am not impressed with the bone stimulators. And I know there's plenty of data out there that say these things really make a difference, but they haven't been a big part of my practice.
Thank you. Thank you for the talk. This is Dr. Stripler. I'm gonna push back a little bit on your concept, and I think because you as you're operating on all the patients, I don't think you see the patient that are in orthosis. I would say my practice is probably 180 degrees different from yours, and in the end, my patients do very well with a stable fibrous non-union. If the patients are 80 or 90 years old, they're in a collar. I think collars are very bad for patients, actually. So I don't even keep them in for 12 weeks. And I think you also showed this in a paper that the complication rate is just 30% just with a collar. So I think collars are bad for people. Yes, I can do a C1, C2 fusion in 2 hours. But if I end up in the same result without surgery, I think I would go without surgery. And I get flexion extension on all these patients after 1 week, 1 month. If they don't have neck pain, it's a really hard sell, to have them undergo surgery. And they have a stable non-union and they go on with their life. So just going to push back a little bit, on that concept.
Well, I accept that because this is a controversial thing. If a patient comes to me with a non-union, stable non-union from what sounds like a remote fracture, and somehow they make their way to me and they don't have symptoms, and so it's not acute, then I'm not going to operate on that patient either. Part of my practice, we're influenced by things that happen to us, and it's not scientific, and it may not be real, but it was real to us. So many years ago now, I had a patient who was exactly that patient. She had a remote fracture, must have had a stable fibrous union. Her son is driving down a residential area. She's bending over to get her purse, and he steps on the brake to avoid hitting a dog. She bumps her head on the dash, and she comes to us a vent-dependent quad. And she, as you work through all the radiographs, she was that patient. And the unfortunate thing, the reason she was so impressive to me, she was my patient. She lived in our hospital for 8 months. They had to rotate her to different units because units would burn out. I mean, it's a testimony to the nursing care there in Iowa because she didn't get a PE, she didn't get pneumonia, and she was miserable in the final days of her life. And so that impacted me, but you're right. There are many people that with fibrous unions that are just doing fine, and I don't deny that.
Yeah, and I think it's a delicate patient conversation, right? It's their decision making, because I think we don't have literature, we don't have guidelines that actually support that kind of treatment of with a color. If you look at the guidelines, you quoted them yourself.
Type 2,
you're out there a little bit on a limb,
The guideline is type 2, level 2.
Yeah.
Our stuff are not level 2. It's level 2 for a fusion in an older patient. And I'll go back to the fact that a 32,000 patient study, 84% of the people are getting operated. And so this isn't just me. There's a broad feeling that surgery is better. And I do believe the mortality data. So we can agree to disagree, but I'm not saying it's bad treatment. I'm not saying that this is totally black and white.
Okay, thank you.
So I wanted to make a couple of comments, Dr. Traynelis. So something that I don't think I ever shared with you in a meeting or anything like that. When I was applying for a residency, it's Steve Papavasilio. I'm a spine neurosurgeon. I've been doing primarily spine for many years now, and I'm the co-director of the Spine Center here. So when I was applying for a residency, maybe 25, 30 years ago, you were in Iowa. So I was a Greek medical student, and I was looking for neurosurgeons of Greek origin to send an email, a letter to try to get to do some work with them. And I assume Traynelis is a Greek name. So I had sent you an email, a letter, and you were very kind enough to respond, please send me your information and I'll be happy to consider. Anyway, I ended up at NIH, but thank you again for being so kind then to a medical student.
Well, anybody that wants to do something, we're always happy to try to help them. But just to clear that up, most people think it's Greek, but it's Lithuanian.
Yes,
yeah,
that's correct.
Yeah,
you're absolutely right. I realized it a few years later. So anyway, thank you for your presentation. A couple of comments. As you know, Augustus White, that you mentioned on your first study, is frequently visiting Boston and has spent a lot of time here with us. Over the last 10 years, every year, the Department of Orthopedics has been organizing an Augustus White conference. And one of them was about C2 odontoid fractures, type 2. And when he was asked, his elder, what treatment would you like for yourself? He would say, put me on a collar for 3 months, which is very interesting, especially since he was the author of the failure of the C collar. The other thing that we see, especially in Boston, I feel, maybe in Chicago, is the shift towards octogenarians on the people that they have the C2 fractures. Most studies are presenting people 65 or 70 and over. And I don't think a lot of us will argue with surgery at the age between 65 and 80. But I think where Martina is coming from is people over 80 with multiple comorbidities. This is where there is a challenge whether to operate or not. And I still question myself, what's the best treatment? And usually the 80s and above is where I'm hesitant to do much. And I've done odontoid screws a lot. I've done about 15 odontoid screws the first 10 years I was here, and pretty successful, but I would usually pick younger people like 50s and 60s. I'm also very concerned about the osteoporosis, like you said. And thank you for bringing up these cystic lesions of the osteoporosis. There's so many times they're read as fractures by radiologists. And we have to be the guys that will say, no, this is not a fracture. This is nothing.
Well, thank you for those comments. I mean, my example was 93. I mean, I accept your comments as they get older. It is true. There's more morbidity. There's more issues that certainly plays into the whole decision-making process.
And I think the paper you presented, all the morbidities, mortalities were in the 80s, if I remember correctly.
But and they are older and immunocompromised, I suppose. My problem was infection, was either pneumonia or sepsis. That was really my problem in those three people. So, but immunocompromised goes with older age as well.
Right.
Dr. Traynelis, in light of that,
As Martina, I'm going to say, as Martina said, it is, if we think about it, if you're experienced in it, it is not a big stress. It's a 2-hour operation. It's a quick, low blood loss event. So the surgery is not that morbid itself.
And, and I have to say, some people complain about the color so much. I'm like, I have a solution for you. I like to do C1 screws. I can fuse you if you want to get rid of the color. But most, and I don't, as I said, they are on a color and they said, oh, no. And, and they can't really turn their head. It would be great if you could get, I like your concept that you put in there of, taking the instrumentation out. It would be great if an odontoid screw would work, but these anterior approaches with the 30% of this fascia and feeding tubes, it's just not a nightmare. But, if you could preserve motion and rotation, I think that puts a lot of people off surgery. With the posterior approach, which we use here mostly. So, but yeah, it would be great if I think you see what equipoise exists here, right? In our small group of spine surgeons here, with that treatment, yeah.
I had a patient last year who was early 50s and markedly unstable odontoid fracture from a skiing accident, and he was sent to me for an anterior screw. And I said, well, we can do this anterior screw, and here's all the stuff about that. But since I'm into this temporary fixation, I said, or we can drop screws in from behind. And he actually chose that, and he healed, and they came out, and he's super happy. He already thought he had dysphagia. He was a little focused on symptoms and just didn't want to take a risk. So that's the only young person I've used, but this person I would have, prior to this experience, I would have just said, we'll put an anterior screw in you and do it. But I have even shifted what I'm doing with some of these younger patients, at least that one.
Well, Vince, I want to thank you. Zeev, the hour is up, so I don't want to take up people's time, but this is a great discussion of obviously controversial, but you've navigated through a lot of this data in a very concise way. And I just want to thank you again for taking the time. I think if people have questions, maybe we can get to you offline if that's okay. Sure. And then go from there. But thanks very much for your time this morning. It was a really, really great run through, and appreciate you doing it. Thanks very much.
My pleasure. And
Thank
if someone
you.
has something, I'm easy to find. Just send me an email.
As Steve found out. Thanks very much.
Have a good day, everyone. Get ready for the cold weather. It's coming.
That's right. Thank you.
Thank you. Bye-bye.
Bye.